day at the hospital said, well, we're going to do Perlock on their eyes. And so one of my students said, what is accommodation? And the nurse didn't know. So did we really do Perlock? No, but we documented we did. Is everybody's pupils exactly the same, right to left?
No.
No. Is that good to know from the beginning?
Yes.
Yes. So if I do my assessment from the beginning and I can see that the left pupil is 1 millimeter bigger than the right pupil, when I pass that patient off to somebody and they're freaking out because now the pupils aren't the same, I need to pass that information on. Or they had cataract surgery and the pupil doesn't dilate as fast as it used to. Things like that. It depends on what's going on with your patient. I mean, if I'm in the super, super bright sunlight, it's going to be a 2 or 3. If I'm in the dark, it's going to be an 8 or 9. It just depends on your patient. You talked about the stroke scale the other day. There's a table in your book right there. That's the pages. Which, you know, in the ebooks, I'm sorry about this. Just go look at the table because sometimes when I look at it on my phone, the page numbers don't match the computer, but the table's the same. So they're assessing all of these things when they're doing that stroke scale. How long does it take to do this?
Like 15, 20 minutes.
Yeah, it takes a little while to do it. I actually have a link to a video that I'll post for you guys. And there's a physician who goes through the whole thing and does the whole thing. I would show it to you, but no internet, you know. Mm-hmm. The score ranges from what to what?
It's from 0 to 40.
0 to 42, I think. Let me double check. It might be 40. You might be right. No, 0 to 42. It is the opposite of the Glasgow-Coma scale. I want my number to be as low as possible. Okay? How high does my number have to be before my patient can get TPA?
Isn't it 20 something?
Over 25. So if my patient scores less than a 25, they're not going to get the TPA because they're hoping that the symptoms will resolve on their own. But they're going to check all these things out: motor skills of the arm and leg, ataxia, best language, dysarthria. What does that mean, dysarthria? Slurred speech. Does that mean I have any deficit mentally? It could just mean that the muscles that make the sounds and form the words aren't working correctly. So that's not the same as best language. Best language is, do they comprehend and can they speak? And then number 10, is it clear? Can I understand it, or is the speech slurred? It measures the severity of neurological deficits, and I'll put in an announcement or something, the link to the video, so you guys can watch the guy doing the stroke scale. Did you talk about the stroke scale at ASLS?
Yes.
Okay, let me ask you this. If you go into the hospital and you are going to have a patient who has a stroke, is just your nurse from graduated 2 weeks ago, got their license, are they going to be responsible for doing this without any training? No. Highly specialized. They want you to know exactly what you're doing. And just like the Glasgow-Coma scale, when I'm giving a report to you, we're going to go in and we're going to do this quickly at the bedside before I leave. So that, yes, so he is looking at exactly what I'm saying, and we can agree before I walk out the door what the score is. Because I might think there's some purposeful movement, or I might hear slurring in the speech, and he might not hear it. So before I leave, I want to make sure, because I don't want to call the doctor later and say, well, I just did his NIS, and he scored an 18. And the doctor will be like, well, that's great, because today when I was there, he scored a 24. You know what I'm saying? He's getting better. So you want to be on the same page with the nurse you're giving a report to. So let's talk about, let's take a break. Come back at the top of the hour. We'll start at 1 o'clock. Reflexes and sensory motor, things like that. Because depending on where the part of the brain is affected, I might lose some of that sensation. It's not my most important thing right now, but let's talk about reflexes. What about reflexes in older people? They're decreased, okay? Let me ask you this. Do TED hose help with decreased reflexes?
No.
No. I just just know that in one of our test banks, there's a question about a patient with decreased reflexes, and everybody wants to put TED hose on them. The answer is to ambulate with the patient and make sure that they're safe when they're ambulating. Because if they have decreased reflexes, you don't want them to fall. What do TED hose do? Circulation. So make sure when you're looking at the questions on the test, you're thinking, why would I put TED hose on this patient if it's a reflex problem? Why would I care about walking with them if it's a circulation problem? Make sure you're asking yourself those questions. The other...
You would want to walk with them if it's circulation.
You would.
Okay.
But do people walk around with poor circulation every day, all day?
Absolutely.
All day, every day. So, right, wouldn't hurt. You don't want to fall in a hospital. Okay. You know how much paperwork there is involved with a fall?
So much.
I'd rather answer a call like than do paperwork for a fall. What about the reflex when you have the person's foot and you run your finger down their foot and their toes flare out? What's that called?
Levinsky's.
Is that normal?
No.
Only normal for babies. So if I have an adult patient and I run my finger up their foot and their toes flare out like that, is that normal?
No.
No, that's something that needs to be investigated. It's called the Babinski reflex. It needs to be investigated. What about an older person's gait? It can be shuffling. It can be slower. Okay. Okay, have a wider stance. So why, when I'm walking, why do I have a wider stance when I'm walking? Balance, because my center of gravity and my balance is off a little bit. So that's normal for an older client to be a little slower, maybe shuffle a little bit, but to have that wider stance so that they have a better base of balance. Let's see what else on here. If I'm walking with this patient and I know that there's gait changes, what area of the brain is that? Cerebellum affects the brain, or affects the gait when they walk. So that's what they're walking him for and noticing that. What's he testing right here when he does this push and pull? Like I want you to push like you're pushing on a brake pedal. Strength. I'm assessing strength. So I'm using flexion and extension to assess the strength. Do I do that on both sides or one side?
Both.
Both. Because if I notice a different strength from right to left, then that's something that I need to report to the doctor. And you're going to have them push like they're pushing on a brake pedal, and then put their toes back up toward their knee, like they're extending and flexing. If you have a patient with a stroke, I'm just going to tell you, a new onset stroke, I'm not talking about somebody who's been in the hospital for 14 days. This is your number one nursing diagnosis, impaired cerebral tissue perfusion. And the goal is to reestablish perfusion to the brain. And the way they're going to do that is with these fibrolytic therapies and endovascular treatments. So this is your TPA. So what do you remember about TPA? Time sensitive. What do you say? It's a thrombolytic, anti-thrombolytic. I need to know the weight because my dosage is completely based on the patient's weight. Okay, the platelet count and what? If they're already on, say it slower. Okay, if they're on an anti-thrombolytic. So if they take Eliquis, Coumadin, if they've been getting Lovenox, things like that. There is no reversal agent for Eliquis though. That's bad when I got Eliquis. Okay, I'm going to give some of the medication as a bolus. I'm going to give some of the medication over the next hour. What did you just say?
The blood sugar.
I need to know their blood sugar. Okay, I'm going to stay with them. Well, they're going to get this either in the ICU or the ER. Somebody's going to be with them most of the time. Okay. Do I care about their blood pressure? Yes. Yes, I care about their blood pressure. Because who do I not want to give this to? Someone who's very hypertensive, over 180, the systolic over 180. So, you're not going to see TPA on your test or your NCLEX, just so you know that. You're going to see the alteplase. because that is the generic name for it, or the trade name for it. It is the only FDA-approved drug for ischemic strokes. The recommended time is 3 hours, but you can go up to 4.5 hours. So that's what they tell. The recommended time for administration is from onset within 3 hours, but most protocols go up to 4.5 hours. Who's eligible for this?
Is there an age, like, they cut off, like, a certain age? Because, like, on our, what is it, ED, it was like over 80. No.
I think it is an IGNY that is over 80 years old, they don't give it.
Now, does it have to be given and completed within the 4.5
No,
hours?
he started with there. So yes, age is a risk factor. The stroke has to be an ischemic stroke. That's why we get the CAT scan first, because if I give this alteplase to a person who has a hemorrhagic stroke, what did I just do?
Kill them.
Yeah, I just made it worse, and I could kill them. They have to have no risk factors for a bleeding event. So I couldn't have had a bleed before. What about a patient who has liver failure? No, they're not a good candidate for this, because usually their platelets are all messed up and their clotting factors are all messed up. What about a person who's had surgery or a heart attack? How long it's been? Usually 3 months. If it's been 3 months, they don't want you to have this medication. So if you had a heart attack on April 1st and it's May 15th, you're not going to be eligible to get this medication. You have to have, go ahead.
Over 3 months.
Has passed the 3 month point. You have to have normal clotting function. So that's why we looked at the PT-INR, and we're gonna look at platelets to make sure that we have normal clotting function. And I'm doing that history to make sure my patient's not a hemophiliac or has some sort of a bleeding disorder before I start. They can't have significant hypertension. The upper range is a systolic blood pressure of 180. If it's over 180, I can't give them TPA. And then
If you give it to them, you just have to get their blood pressure lowered?
you can, but how am I gonna get their blood pressure lower in the time, in the window? Yeah, I'm probably not gonna be able to. And even if I gave them something and brought it down for the moment, it's gonna go right back up, if I'm not careful. The other thing is you can't give it to a patient without knowing the time of onset. So a wake-up stroke, I woke up and I was this way, even though I was normal 10 hours ago, they're ineligible for it.
If they like wanted to take the risk and do it, like,
You work in the ER, don't you? You work in the ER? Do you have a protocol for this down there? Yeah, I'm sure.
Yes, we do.
I'm sure
there's a protocol.
Yeah.
Yeah,
Because I don't want to be, I'm gonna treat every patient the same, and I don't need to be calling the doctor to find out what I'm supposed to do. There's a written protocol. If this, then that, it has algorithms for everything you do. I know they have it at Singing River and Ocean Springs.
It's the 25 or over. It's the 25 or over.
What do you mean?
The score.
Yes, your score on that NIS has to be 25 or greater. If it's less than 25, they're not going to give it to you. Do I need an informed consent to give this drug?
Yes.
Yes. Who can sign an informed consent?
The patient can.
Patient, if they're able.
Or family member.
A power of attorney, if they have a power of attorney for health care.
can they do the 2 doctor?
They can do the 2 doctors if the patient can't do it. It can be 2 doctors saying that they need this medication. The spouse can sign the paperwork. It's always good to have a durable power of attorney though. Yes.
Is that different from hospital to hospital? Because when my dad had his stroke symptoms, they didn't even ask me. They took him straight to CT and I signed consent. So does it depend on the situation?
What do you mean they didn't ask you?
Like, they didn't ask if I had power of attorney over him or anything. They just told me to sign consent.
Yeah. You can sign, a family member can sign the consent. Usually they look for a spouse first, but a child can sign the consent. Anybody can sign that consent. Because what do they have to tell you when you sign an informed consent? Benefits, the risks, what's gonna happen if you don't do it, the procedure, you have to know what this medication's for and what can happen if the patient gets it or doesn't get it. Let's see what else. So I have to have my vital signs and the neurological exam complete. My CAT scan has to be done. I have to go through my list of what's included and what's not included. Do you remember what the dose is?
0.9 per kilogram.
0.9
Per kilogram up to
kilogram.
90 kilograms.
up to 90 kilograms. So there is a max dose. So if your patient's huge, there's a max dose. But it's weight based. So I need to know what my patient weighs. 0.9 milligrams per kilogram up to a dose of 90 milligrams. How much is given as a bolus? 10%.
Yeah.
So if my patient's supposed to get 54 milligrams,
5.4.
5.4 milligrams will be given as a bolus first. How do I give a bolus of medication? Push it. You don't, yes. I'm just gonna tell you, has anybody given heparin at the hospital? Like had a heparin drip?
Yeah.
Well, heparin comes 25,000 units in a, I think it's a 500 cc bag, it's like the standard dose. And I've seen nurses go, I'm gonna give a bolus of whatever, and they program it in the pump. And so you're standing there waiting an hour for this bolus to go in. That is not a bolus. A bolus is given IV push. But when it comes to medications, a bolus fluid, you can give over an hour. When am I gonna stop this? If my patient's getting the medication, we're like 47 minutes in, what kind of things am I looking for that I would stop this? Bleeding, petechiae, a headache, a severe headache. Because if they're bleeding in their brain, they're gonna have a headache. What else am I gonna look for? One other thing. Okay, nausea, vomiting. Okay, I'm still assessing level of consciousness. What about their blood pressure? If their blood pressure goes up over that 180, the systolic over 180, I'm gonna stop this infusion. So that's why when you said, can I treat the blood pressure and have the blood pressure come down? If I don't do something pretty permanent, it's not gonna stay down. So I'm just gonna
Stop
do
it for
something.
nausea and vomiting, or you just pretty much.
You stop it for nausea, vomiting, that high blood pressure, severe headache, and acute hypertension. You'll see that they'll get petechiae on their chest. What I want you to think about with this, and I'm going to tell you this: there's not a question on your test that tells you doesn't give you the information that you can't answer with how much they get. 0.9 milligrams per kilogram, blah blah blah. Okay, it's a good dosage Cal question though. Just but this is what I want you to think about when you're taking your test and your final exam. I want you to think about patient safety. Who can get it? Who can't get it? What am I monitoring? What am I looking for? When am I going to stop it? When am I going to not give it at all? I want you to be thinking about patient safety, okay? I can't promise you that this drug won't show up on your NCLEX, and you'll have to do something, but...
Okay, so they've already gotten their bolus 10%, and we're starting that IV drip of it. Is there any other medication that they can give them while they're on this, or that is it?
You can give them med at the same time, but you can still monitor that blood pressure, because if it goes back up, you gotta stop this. You don't want that blood pressure going over 180 systolic, or you're gonna stop the medication. So, I want you to think about patient safety issues, bleeding in particular. You can't run
But anything that's
through that
TPA.
IV where the TPA is running. It's a dedicated IV site. Yes. Kilograms. If it's per milligram per kilogram, up to 90. If the patient weighs over 90 kilograms, that's it. Then you calculate it at 90 kilograms. So, if this is a question that you could see on a test or a final, to where you calculate the dose, okay? I'm giving you all the information you need to calculate this dose. You don't have to solve this here, and I'm just gonna tell you on the next slide, there's the answer. I want you to go home and work the problem out though, make sure you understand how to do it, okay? If you don't, you can send me a message in the Dropbox, I'll put a Dropbox out there, and we'll talk about it. But if I give you the weight, what do you gotta do here? Convert it to kilograms. I give you the dose. I give you that the 10% is given over 1 minute. And so you have everything you need there to calculate it out, okay? And then the answer's on the next slide. And I'll post these this afternoon. So, which ones of these are contraindications to the TPA? Concomitant is surgery. Yeah, surgery and the infarction is 3 months. What about G? Right, if my patient is improving, they're not, if you came in and you scored a 28, and you're improving, you're a 25, and now you're a 20, you're not getting it. C is okay, because the blood pressure is 180.
What if they're like a 35 and they're a 30 and they're...
As long as you see improvement, you're not gonna get it. Because think about it, if you're improving, if you come in 45 minutes from the door of the ER till the TPA starts, and you've improved from 35 to 30, that's pretty good improvement with 45 minutes or so. So as long as they're seeing improvement, they're not gonna start it. Does that make sense? No need to. So, what are core measures? Anybody know what core measures are? It's a standard set by the Joint Commission for different things. It's there's core measures for as a baby, there's core measures for pneumonia, there's core measures for UTI. Each hospital has to pick 5 core measures that they collect data on and measure. If the hospital chooses to do strokes as one of their core measures, these are the things that have to be documented and done before that patient's discharged. They have to have venous thromboembolism prevention. What does that mean?
Blood clots. To prevent blood clots.
Okay, so what am I documenting?
Hose, ambulation.
Okay, my patient ambulated, that I had SCDs on. If my patient gets Lovenox, when can I get Lovenox after TPA? 24 hours. So my patient got Lovenox. Who documents that stuff? The nurse. So if you don't bother to go down through your little note and click the box saying your patient was wearing SCDs, even if they had them on every single day, was it done? No. Nope. So you didn't meet that standard. So the nurse is responsible to make sure it's documented that you met that standard. They go home with an antithrombolytic. So what are they going to go home with?
Warfarin.
Okay, warfarin, Eliquis, Xarelto, one of those drugs. They're going to go home on one of those. If your patient has AFib or aflutter, it has to be documented that they're on some sort of anticoagulation for that. That's one of the core measures. The thrombolytic therapy must be initiated within 4 hours of the time of onset. That's the core measure. They can get it up to 4.5, but if you didn't get it within 4, you don't meet the core measure.
Wait, if
Go ahead.
they don't get the therapy within 4 hours, and then like months later, can they ever have thrombolytic therapy again? Like they,
If they have another stroke? Yeah, if they have another stroke, they can. But you can give it up to 4.5 hours, but you don't meet the core measure if you don't give it within 4. That's the core measure. Hospitals are rated on this stuff, and it's public knowledge. You can go in and look up and see what does your hospital, which 5 did they choose, and did they meet the core measures for those 5 things. Discharge the patient home on a statin drug. Why is that important? High cholesterol. What about have high cholesterol? Yeah, even if I had a stroke, I'm discharged on a statin drug, even if my cholesterol is normal. because it prevents, problems in the future. Stroke education is provided and documented. I can tell you all day long, if you have any symptoms, you can come back to the emergency room. If it's not documented, I didn't do it.
Why does your cholesterol fluctuate after a stroke? Like what is,
It doesn't, but even if you don't have high cholesterol, you're going home with a statin drug prophylactically. Yep.
So 5, that's just talking about the TPA, if it was effective or not?
Yes, it's talking about the evaluation of the TPA, and then if you put the patient on, anything like warfarin, you have to have documented that you're doing PT-INRs. Education. If I don't document it, it wasn't done. I'm gonna tell you, memorials charts are the hardest to navigate to find what patient teaching's been done. It's near impossible. They have little checklists for care plans and stuff, but it's hard to find what teaching's actually been done. Like, what did you say to the patient? That's huge though, because if I don't have it documented, it wasn't done at all. And then this rehab assessment, so just like my dad was admitted for 2 days with his stroke, he didn't go to rehab. But they had to have a rehab come and assess him at the hospital and say he doesn't need inpatient rehab. It has to be documented that they came, somebody assessed him, and he does or does not need to go to inpatient rehab. If it's not inpatient rehab, what's the recommendation? That has to be documented. So those are the 8 core measures for the ischemic stroke. The endovascular treatments, I know you talked a little bit about those at ASLS, but this is what they are. A mechanical thrombectomy, carotid angioplasty and stenting, and carotid endarterectomy. I'm gonna tell you, the carotid endarterectomy is not in your book, but you need to know about it, because you're gonna see them in practice, and you're gonna see them on the NCLEX. I think that it's on your syllabus though, so we're gonna talk about it.
Cool.
So the thrombectomy, they go in there with their little rotor-rooter thing, and they grab the clot and they pull it out. How do you access that? Through the femoral artery. Sometimes they can do it through the radial artery. So what is my risk there with my patient?
Bleeding.
Bleeding. So my patient comes back, they had this done. What kind of things am I looking for and assessing?
Incision size.
Okay,
Pulses.
peripheral pulses on right or left? Right. Look, I'm gonna do bilateral. So, you have a little patient, they have real weak pulses to begin with. What's the best thing to do before they go down for the procedure? Take that surgical marker and mark their pulse, so when they come back, you don't have trouble finding the pulse. Because if it's weak to begin with, and now it's absent, you might not be able to find it. If they don't have pulses, what's gonna happen to the leg? Yeah. They're gonna have to go back and either open that up to reperfuse, or they could end up actually losing their extremity. This is the least invasive of the procedures, to go in and do this thrombectomy. All they do is go in there, grab a hold of the clot or the plaque that's blocking the blood flow and pull it out. Stenting, they go in the same way, but just like cardiac stents, they go in with the metal stent and they block that open so that it doesn't close off. Is that 100% foolproof?
No.
Nope.
No. They can close off too, because you have the plaque on the outside here, but if the patient doesn't make some lifestyle changes, pretty soon you have plaque on the inside and it's gonna block back off. So, it's not 100%. How do they access the patient to get that in? Through the groin, usually through the femoral artery or the radial artery. So my risk is the same, bleeding. When my patient gets back, I definitely want to be checking circulation and things like that on the patient. Here's your carotid endarterectomy. This is why it's important to know about this. They actually go in and make an incision right here on the patient's neck. They make an incision on the on the blood vessel itself, and they pull out the blood clot or the plaque or whatever is causing the blockage. So if my patient has this, what do you think some things I need to think about when I'm taking care of this patient?
Airway.
Okay, airway, because if I have a big hematoma, a rupture. So he's a surgical patient. Do I want him turn, cough, and deep breathing?
No.
Do I want him, go ahead. Okay, I want him to turn and deep breathe, but I don't want him forcefully coughing, because,
Cut it busted open.
yeah, the sutures right here can break open. This guy's usually gonna spend 1 night in ICU before he's discharged from the hospital. When we talked the other day about intracranial pressure, and we talked about the head of the bed being up or down, where do you think you want his head? I want him up about 30 degrees. And do I want his head to be straight, midline, or whatever? Yeah, I want him to have his head supported. Sometimes they'll actually support, just like when you have an abdominal incision, you know how they teach you to support with the pillow? They'll actually have them split when they turn their head. Or if some patients just have to cough, if you have to cough, I want you splinting that area so that you're not putting a lot of pressure on it. He might have a JP drain. Why is a JP drain important? What kind of maintenance? Right, if I'm not pulling anything out of that drain, where's that fluid accumulating? Right there at the site. And so I can have some pressure and occlusion from that also. So I need to make sure that if I have JP drain, I'm doing that. Anything I might want to have at the bedside? Suction. A trach kit possibly. O2. If he has an occlusion, like let's just say we have this is intact, but I have a blood clot that formed there, what would I hear if I listened to it?
Brewy.
A brewy. What's a brewy sound like? A swishing sound. I would hear the swishing sound there. So when I'm assessing my patient, I'm actually gonna listen to hear if there's a carotid brewing on either side.
Would he be NPO?
Before the surgery, but not after. Not after.
Yeah, special diet for soft.
He might have a soft diet for the first 24 hours, but no. But I'm monitoring for hemorrhage, I'm monitoring for respiratory distress. What if my patient has changes in speech or swallowing? Well, I could have some sort of cranial nerve damage, because there's a lot of, the cranial nerve with the chewing runs down through here, and I need to make sure I don't have some cranial nerve damage there. You might hear some slurred speech if they have the damage to the cranial nerves that affect the mouth. But the important thing I want you to think about is patient safety right here. Do I want him to ambulate? Sure. Yeah, he can ambulate. I don't want him out running a race where this is Alton, but he can ambulate. The turn, cough, and deep breathe is the big thing. I don't want him coughing. I can use the incentives barometer. I can breathe deep. I can turn, but I just want to make sure that I'm not doing any forceful coughing or sneezing. It's putting pressure right there on that anastomosis where they put that back together. Yes, just swing with their hand. Just like when we talked about the cervical fusion.